I call upon Osgay to continue the presentation from HQ.
Thank you very much, colleagues. Greetings from Geneva, Switzerland. We would have definitely wished to be there with you on site. Unfortunately, we couldn't, but thank you very much for accommodating us online. I think we're going to start this presentation, and my colleague, Dr. Mertash, will be taking on to tell you a little bit about how the antenatal care recommendations and guidelines came about at the global level, and how, with the trailblazing efforts in Tamil Nadu and with partnership with India and other countries, that we've actually been seeing how we can implement it in an efficient, effective, and in a way that actually improves quality of care for women and communities. With this implementation research, in the context of implementation research. So it is a great pleasure for us to be here to share some of this thinking and some of this work with you. And with that, I will leave the floor to my colleague, Hediye. Over to you.
Thank you so much, Özge, and hi, good afternoon, colleagues, and thank you for tuning into this session. We're really excited to present our sort of global level recommendations on antenatal care. So just to give you a snapshot of how the guideline development process occurs here at WHO, and specifically for this set of recommendations, it's a rigorous process that follows multiple systematic reviews and really taking on an evidence-based approach and person-centered care approach to develop the guidelines. And here we just have a few of the the publications that were used to inform part of this process. Next slide, please. And so as a result, in 2016, the new antenatal care recommendations were published. They're grouped under 5 areas: nutritional interventions, maternal and fetal assessment, preventative measures, interventions for common physiological symptoms, and health systems, in addition to other routine ANC recommendations that were used as part of the guideline, totaling up to around 49 recommendations. Next slide, please. With the overarching aim to provide women with respectful, individualized care to ensure clinical practices such as tests and interventions are provided in a timely manner, inclusive of emotional support and well-functioning health systems. So really taking on this really holistic approach to be able to deliver good quality antenatal care services for women. Next slide, please. So just to give you a snapshot of what some of the key updates were in this document. So previous to the 2016 ANC recommendations, the number of contacts were 4. But based on new evidence, the contacts are now up to 8 weeks, up to 8 contacts, up to 40 weeks. So encouraging. So it's part of to encourage women to attend antenatal care sessions more as part of their pregnancy journey. And what is a contact versus a visit? It's really about having all the outcomes improve towards maternal health. So really ensuring that all the tests and all the different areas that need to be addressed are addressed within those 8 contacts. Next slide, please. Thanks. And the other one was around ultrasound. So recommending ultrasound before 24 weeks and initiating early ultrasound for women to ensure that anomalies and other issues are addressed. And the other area was also health systems. So ensuring that there's continuity of care and integrated as part of the continuum of maternity care, and ensuring that health workers have what they need to deliver a good quality of care. Next slide, please. So we have the global recommendations that were evidence-based, and we just gave you a snapshot of sort of what the recommendations were. In addition, WHO has developed an adaptation toolkit. So this was the adaptation toolkit and monitoring framework that was used by the countries in the study, but also available to use for countries globally to be able to adapt the recommendations to the global setting. As we know, different settings have different contextual requirements. And so as part of that, as part of this process, we have an adaptation and tool and monitoring framework that countries are able to use to adapt these recommendations. And our colleagues in both Tamil Nadu state and Assam, with our partner Jopaigo, were able to use this to be able to adapt the recommendations to the local setting. And our colleague Ramya will go through how that was contextualized and operationalized in India. Next slide, please. So just to give you a background of what we wanted to give you a quick snapshot on. So we also, as mentioned, like we have the adaptation toolkit, we have the guidelines, but how can we actually implement and test and evaluate the effectiveness and the acceptability and feasibility of this package contextualized across different studies? And so that's how the new antenatal model of antenatal care in Africa and India research study came about. It's an implementation research study using these guidelines with different adaptations across different contexts to really transition from the planning phase and having a sort of set of recommendations to how do you actually now test these country-specific practices and ensure that we have the right results to be able to move forward for sustainability and scalability of these recommendations in country. And so it's really been a collaborative effort over the past 4 or 5 years with the WHO country office, with regional office, with the national ministries of health, state health, other partners, including Jopaigo, for example, in India, and local research partners that have really been able to form this consortium to move this research forward. Next slide, please. So just to give you a snapshot, it's happening, and it's this testing of the applicability of these recommendations has occurred in 4 countries: Burkina Faso, India, Rwanda, and Zambia. And specifically in India, as you may know, it's been in Assam state and Tamil Nadu state, and the results will inform hopefully what will happen after. So next slide, please. And a brief snapshot of how this study was actually designed. It's a stepped wedge cluster randomized control trial. So since it's a large package, a stepped wedge control trial allows you to implement the package in various intervals. So it's not that, every facility receives the package at the same time, which then could potentially overwhelm the health system. And so in this sequential manner with a stepped wedge control trial, it was done across 6 periods, each period consisting of 4 months. So in India and Burkina Faso, these were done in 4 clusters with 1 to 2 facilities per cluster. And so there was a baseline to be able to baseline both quantitative and qualitative to be able to assess sort of what the formative sort of what is the understanding of ANC services, and then the adapted package was implemented across each country. So this is just giving you a snapshot of how this was. And then by the end of it, by the end of period 6, all facilities were receiving the package, which is really exciting then to see sort of over time how the implementation of the package was received. Next slide, please. And in order to support sort of how this was implemented, there was a series of co-interventions that were developed, which include training of staff on the ANC package, supportive supervision on the recommendations, ensuring availability of supplies and commodities such as tests and other areas and for supplies that are needed. Community sensitization, as we know, early ANC initiation is critical to have sort of a community component that's contextual. And also there was a digital component in certain countries that wanted to test the package digitally. Next slide, please. And so this is just a snapshot of our outcome indicators. Our protocol is published online, but just to give you a snapshot, these were some of the outcomes that were around sort of early initiation of ANC, syphilis, hemoglobin testing, and then total number of ANC contacts for us to see the trend across time and to be able to, advocate for the fact that this was successful and that we can really plan for sustainability and scale up. Next slide, please. And just to give you sort of looking into the future, what can be done. So WHO is now shifting from the ANC recommendations that are, of course, it's a document, but how do you actually now integrate this as part of countries' digital health systems? And so moving to that, we have this is just a snapshot of how one can transform the guidelines into a digital module that can be integrated within the current digital systems or used separately within facilities as part of that. And so it's just sort of next steps for like how the recommendations can be used more effectively. Next slide, please. So looking into the future, I've mentioned that giving hints of what we're really anticipating in the next couple of months and the next year. So really, we're now wrapping up the study. Tamil Nadu has just finished their study. Assam, we are cleaning the data. And so we're working with all the country partners across those 4 sites to publish the results of the study, which will be critical and crucial to sort of inform the next point that I have, is to engage with stakeholders that are in the room. I apologize that we're not there, but to engage with you on dissemination and planning of how we can now sustain this package and sort of move forward to make sure that it's embedded within the health system. And of course, to incorporate, so our global guidance doesn't stop here. So how do we incorporate the study findings and WHO's global guidance for implementation, and so that we can use these findings to be able to then have a global guidance on really implementing it and sort of best practices through this study. That's all from us. Thank you so much, and happy to take questions thank you. And thanks to all of our teams and research partners. We're really, we wouldn't be able to have done this without them. Thanks.
Thank you very much. On behalf of chairs, we would like to introduce this session. Actually, we started very abruptly. Warm greetings to all of you on behalf of WHO India. Our SQ colleagues, they had to disconnect at 1:30. So we started with this presentation. Now Dr. Ramya will introduce the panelist and chair, and she will share with you about the India story, the Tamil Nadu story. She will have a lot of sharing and a lot of learnings, and it will be really a good example of very good high-performing states, how they can implement the new ANC guidelines here. Okay, so over to Ramya.
First of all, thank you everyone. And thank you so much, Azke and Hedaya, to take time and support us throughout the study with all the time restrictions that we've been having. I would also like to thank Dr. Pushpa ma'am, the team lead of RMNCAH, without whom had spearheaded the project of ANCIR in India. I also thank all the other dignitaries, Dr. Krishnalila ma'am, JD NHM, Dr. Nirmalsan sir, JD DPH, Dr. Yashodamani ma'am, and Dr. Kalusalingmu sir. Special thanks to Dr. Priyanka, who couldn't be here because of certain reasons, and Abu as well, who's my counterpart in Assam. Also, I would like to specially thank my predecessors, Dr. Manoj and Bharani, without whom we could not have come so far. So, shall I continue with my presentation? Slides, please. So I would be talking about field perspectives and observations. And the next slide. So like Hedaya and Ozge had already mentioned, this is the study aim. And it was to use implementation science for systematically introducing and testing the applicability of the adapted WHO antenatal care package for positive pregnancy experience. There's also another document that all of us could go through for positive pregnancy experience as well. Next slide. So the 2 states were selected based on Government of India's recommendations. One was Assam and one was Tamil Nadu, in which 2 blocks were selected. In Tamil Nadu, we selected Virudhunagar and Viluppuram, of which 8 blocks were again selected for implementation. So the objectives of implementation research, I think Hedaya and Ozge have already covered. So in a nutshell, what we did was to implement an 8 ANC contact model. We initially started to understand the existing system in Tamil Nadu and Assam separately because we do have separate systems. Tamil Nadu being a high-performing state and we've already crossed the SDG, we had to conduct rapid baseline assessments to find out where we stand. Secondly, we had to reorganize the existing ANC system. It's just that the stakeholders involved were also involved in these meetings. Leveraging on mid-level service providers, that's where the DDs and JDs were involved. Training of ANMs, MO on new revamped ANC package was done. This was done in 6 different types and in the implementation category that was explained in the step wedge ladder pattern. Regular assessments were also done to measure the progress. Next slide. So a short thing about how we contextualization of India and in Assam and Tamil Nadu was identification of states by GeoVibe. I already told you that. And then the second thing was situational assessment conducted in both the states. That was done by a third party in 2019, post which JPIGO was introduced as an implementation partner. And then tag teams were selected in both the states, which conducted of NHM and other partners. The next slide. In Tamil Nadu, so we had focused on 4 different patterns. One was training of ANC staff package, supportive supervision was given, ensuring availability of resources. For the same, there were 8 versions that were conducted and all of the resources were regularly monitored. Community outreach was also done. This was done during the ANMs and the MOs as well. Next slide. So this was the initial OSCE score that we had conducted to know about the knowledge assessment pre and post training. Next slide. This is the achievement that we see so far. The 8 contacts were actually incorporated into the new RCH register that Maternal Health Department had presented. Next slide. And this is how it looks on the page on the register. I think medical officers here would know it better. Next slide. Next. And this is the way forward. So like OSGE and Hedaya had told, time motion study data collection is completed. Qualitative data completion is collected, but in Virupuram we are still collecting period 6. And then continuous improvement of data quality is also being done because we have implementation partners from JPIGO going in person and getting the records done. Sharing preliminary results with the stakeholders and finalizing data analysis and dissemination plan would be in 2025. That's all. Thank you. So if there's any questions, do let me know. Yes, ma'am.
So, good afternoon all. So I have 3 questions for you. So the first is, that is the baseline is AN visit, 4 AN visits to be
Yes,
given,
ma'am.
should be given to the AN mother. In Tamil Nadu, that is non-high risk women, antenatal women have 8 visits and more, and high risk women around 10 visits or more.
Yes, ma'am.
So in that condition, why you have chosen Tamil Nadu and Assam? First question. Then second, why you have chosen that 2 blocks, Vilupuram and Virudhunagar? Right. The second one is, so far in this study, that is, what are the positive points you have observed from the healthcare providers as well as from the patient, and the gaps to be fulfilled from the patient as well as that is AN mother and healthcare patients. The third one is, what's the special important outcome of this study? So based on some indicators, you have told something, but what do you expect? What is your expectation? That is the outcome, important outcome.
The outcome. So initially, to answer your first question, ma'am, India as such is got out 4 ANC, government national guidelines. But Tamil Nadu State, being a medical officer myself, I started my career in the corporation. We have done more than 13 visits. But to standardize that and make sure that it's become a formation of guidelines. So in case we have these results in a positive manner, we can show these results to the GOI and they can implement it throughout the country. That was the first way. The second thing why Assam and Tamil Nadu were selected was in comparison of a high performing state and low performing state, ma'am. That was why these 2 states were selected. To answer your third question, the positive outcome is the experience that the mother has, ma'am, altogether. There's a difference between a visit and a contact. So initially, when we used to see patients, even if they come for a fever or some kind of ailment, that was also considered a contact or a visit. But in this, we have a particular reason as to why they're coming for a contact and what needs to be measured during the contact, ma'am. It's just to standardize the care all over the country and the world. It's just that, ma'am. Thank you.
I would like to add, these two districts were selected by the government of Tamil Nadu, and there was a initial delay because they selected another district first, but that was changed. Actually, the government of India chose one high-performing state and one low-performing state based on MMR. And the reason is like this new ANC model, if it is implemented in a state where very strong health system, what are the learnings? There is always some learnings, you know. How it is different when these visits are changed into active contacts. They are added a package of intervention that were not there. So these learnings could be replicated in those states who are, you know, better performing or high performing. So this is on recommendation of Government of India that Tamil Nadu state was chosen.
All right, thank you, ma'am. We should proceed to the moderating session. The session chairs will be Dr. Pushpa ma'am and Dr. Krishnila ma'am. So I have just 3 questions. It's a common question, sir. So one was, I think this is more of a HQ question. So what contextual factors have you identified as critical to the successful implementation of antenatal care programs in diverse settings? So Ozgi, do you mind answering that?
Of course. Thank you. Thank you very much. And thanks, colleagues. I'll have to leave after this for another workshop related to quality of care and respectful care, actually. Very related areas, talking about positive pregnancy and birth and postnatal experience. But I think one of the things about context is we have been very focused as we are developing recommendations on the effectiveness of interventions, which is very important. But when you think about how those interventions can be implemented in the settings that we would like to make that impact, then it becomes a bit more trickier. And one thing that we started doing is, before waiting for the recommendation to come out, I think one of the things now we are more constantly doing is trying to understand the aspects of acceptability, feasibility, and implementation of any recommendation that WHO is putting out there. So how can we synthesize the evidence from the health work perspective, from the health system perspective, from the communities and women and partners and families perspective, so that when we actually issue a recommendation, we can already start talking about context and some contextual factors that will have implications on the success of an intervention or not. So for the whole antenatal care guideline, this is the approach that we did. So we actually did a huge Cochrane review, synthesizing evidence from around the world, high, low, middle-income country settings, trying to understand what actually affects women to come to the services and keep coming to the services. And also from the provider's perspective, what are the factors that actually enable them to provide the good quality care? So when you look at those co-interventions and when you look at the way we have been adapting the ANC, WHO's ANC package in the context of Tamil Nadu, for example, these are all the factors that we've already started thinking before going into the field. Because health systems, community, the teamwork that is happening at the level of service provision, financing, how the financing works, the continuity of care, all of these factors can make or break the successful implementation of an intervention. And in the case of antenatal care, it is basically a platform of interventions. And I want to say integration because when you think of antenatal care, and when I talk to our colleagues as well, we always think of maternal health. And, you know, maternal health, of course, that's where the basis is. But if you look at the recommendations and if you look at the kind of care a pregnant woman needs during pregnancy, it includes malaria care, it includes HIV, it includes maternal immunization like tetanus and possibly into the future RSV. So how do we ensure that when we are implementing a platform of interventions or strengthening a platform like antenatal care, how do we ensure that across the house, in the Ministry of Health or in WHO across different departments, how can we make sure that we are all coming around the same table? Because at the end of the day, person-centered care means that we come around the table to be able to provide the most complete and good quality services to the user, in this case, women and families who are coming to care, to get ready for their birth and for their life as a family. So I think those are the kind of factors that are really important for us to think about at the development stage, planning stage, and implementation stage. And if you look at all the countries who have been doing this research, there are differences between Tamil Nadu and Assam. There are differences between Burkina Faso, Rwanda, and Zambia, which is what it should be, because we are operating in different health systems and different populations with different needs. And those are the things that we need to think about across all of these stages if you really want successful implementation and impact. So I'll stop here. Thank you very much.
Thank you so much, Ashke. That was very well. Thanks. So, ma'am, do you have anything to say about anything to add? Anything to add, sir? Priyanka, ma'am, do you have anything to add?
Thanks, Ramya, and all the points are covered. And I thank Dr. Pushpa and the Tamil Nadu team, DPH and NHM, and our HQ team to be here. So most of the points are covered. In interest of time, I'll over to you, Ramya.
All right. Ma'am, should I proceed with the next question? All right. The next question is, so what do you think are the primary barriers to implementing antenatal care interventions, and what approaches have been effective in overcoming them?
Self DHO Virudhunagar. The main barrier was shortage of skill training healthcare providers, which was addressed by the JAPEGO team. Various level of training and capacity building were given to the VHNs and ANMs and Anganwadi workers also. Another barrier was the distance to the healthcare facilities. That is a constraint, and the travel cost and also loss of wage while seeking the healthcare behavior, and also lack of awareness among AN mother while seeking healthcare. Culturals and customs beliefs were there. Recently we have lost one mother due to this she was possessed by a spirit, and they were taken to a temple and all. So these are the barriers need to be addressed. Thank you.
Thank you, ma'am. Thank you so much. The next question, do you have anything to add, ma'am? Okay. Do you have anything to add, sir, for the same? Any barriers that you would see?
Yes, sir. So this we want to have a research gap. We want to do what are the what can we do our best regarding the antenatal care. What are the gaps? As rightly pointed out by our respected direct DPs are in the early inaugural session. ANC care is equally important as conducting delivery. So we have to sensitize all our staff regarding the quality, efficient, effective antenatal care. Thank you.
Thank you, sir. Thank you. So for the final question, ma'am, in what ways technology can enhance the implementation and delivery of antenatal care services? Krishnila, ma'am, your thoughts?
Of course, technology plays a dominant and important role in the healthcare delivery system. So in Tamil Nadu, we are having that is a web portal, that is Speak Me, pregnancy infant cohort monitoring and evaluation. So in that we can capture the detail, all the data related with the antenatal as well as postnatal women since from conception till 16 years of age. And another important point is in this portal, the portal is being integrated with the other departments, that is ICDS, 108 ambulance service, 102 service, and private medical colleges and hospitals. And the portal can be used. We are having 3 directorates, that is the Director of Public Preventive Medicine, the Director of Medical Service, and Director of Medical Education. All the directorates can be easily use the portal and they can enter the data. So, like this, from this portal, we can give the healthcare service continuously and can reduce indirectly or directly reduce the infant mortality rate as well as maternal mortality rate. And we can trace the high risk antenatal mothers as well as postnatal mothers. So that's why IT platform is very useful in healthcare provisions.
Thank you so much, ma'am. We can conclude the session, sir.
So thank you, ma'am. So from WHO side, we want to extend our to WHO, ma'am and Pushpa ma'am and Priyanka Singh. So we like to extend our sincere thanks to you for coming all over from Delhi to here. So we like to have this innovative technological partnership from WHO side to implement that in the future. Because as Madam said, we do have the PICME portal, but to enter into the PICME portal, we need to enter manually through the computers. So we do have some sort of, we have ensured on Bluetooth linked devices which can tap other things. So from when we are taking the investigations in the field, it can automatically go into the PICME portal or in that kind of a thing. So there is a lot of Bluetooth linked available devices are there. So that we can link that to the app. So if possible, we are expecting from support from the WHO to do that in Tamil Nadu, ma'am, on a pilot basis. Thank you, ma'am. Thank you for your support. Thank you.
Thank you, everyone.
So as Tamil Nadu is trying to achieve that last mile of reducing low MMR to further low, this is very challenging. And I understand that you are really focusing very well on tracking all high-risk pregnant women. The last mile is always about equity. Who are those and which pockets are those who are not coming into the system? So I'm very glad, to have partnership with Tamil Nadu government, as a technical partner. We are always there to support. And we are, waiting for the findings of this implementation research, because that will really give us some, idea about how to improve further, how these learnings can be replicated and further improved to detect all those high-risk pregnancies, that need immediate interventions. So this implementation research is really, we are glad that Government of India brought it to Tamil Nadu, and we could work with people who are so much dedicated and motivated in a strong health system, because ultimately it's the accountability that really matters, and we can see a high level of accountability here in people who are serving in the public health system. So we look forward to further engagement, and we assure you that it's a partnership that we also very privileged of. Thank you, Ramya, and thank you everyone for coming to this session and sharing your viewpoints and enriching this session of WHO. Thank you.
Thank you for the wonderful session. I would like to request Dr. P. Sampath, Additional Director, Disease Control, to felicitate the panelists. Dr. Pushpa Chowdhury, Team Lead. Dr. Krishna Leela. Dr. Nirmal Sen. Dr. Kalusivalingam, Dr. Yasodamani, Dr. Ramya.